Well, thank you for the opportunity to talk about complementary and alternative therapies in ENT. I've always wondered as a clinician, what is the evidence? Neither I nor any members of the planning committee have any actual or potential conflict of interest in relation to this presentation. So I just want to get this disclosure out of the way. So these are the objectives for the next 25 or 30 minutes. I want to define complementary and alternative therapies. I'd like to recognize some common complementary and alternative therapies that patients may use for ENT disorders, and then examine the current evidence for some of these complementary and alternative therapies that our patients are using. So why give a talk about CAM, or complementary and alternative medicine? Well, these days, patients are getting a lot of their medical information from social media. So they'll come into the office and tell us about what they learned on YouTube, Twitter, Instagram, Facebook, Netflix, you name it. And furthermore, artificial intelligence marketing tools saturate the user's social media accounts with homogeneous and skewed, often perhaps inaccurate data. So when the patients come into the office, they come in very well read on complementary and alternative therapies, but that knowledge base could potentially contain some false information. There is a place where we can go as clinicians for evidence-based approach to complementary and alternative medicine. So the National Institutes of Health has a National Center for Complementary and Integrative Health. So I'd like to refer you to the website. You can go there and get important patient education information. You can go there and find papers on clinical trials with respect to evidence-based medicine, and even watch lectures for CME with respect to evidence-based approaches to complementary and alternative medicine. We'll briefly talk about some definitions. Complementary and alternative are often used interchangeably, but they're different. So complementary therapies are non-mainstream practices that are used with conventional medicine. And so by nature of patients being in our offices, they're probably going to fall into the category of using complementary therapies, whereas alternative therapies are non-mainstream practices that are used in place of conventional medicine. Complementary and alternative medicine is rising in the United States, so the use of those therapies is increasing. This is a 2012 survey that showed that a third of adults and about 12% of children are using complementary and alternative therapies, and I would argue that that number is probably higher today. When you look at, I should mention that that previous 1/3 of the population number excludes vitamins and minerals, and when you look at vitamin and mineral use, that's much higher. So 63% of the population will tell you that they use any vitamin or mineral supplement. And when you look at multivitamins, 33% of folks in the United States use it across all ages. And you'll find that the highest usage is in women over age 50, where about 50% of them are using multivitamins. So this is an overview of what I'd like to cover today. These are some of the complementary and alternative therapies that patients in my practice have queried me about, and I've always struggled to find a comprehensive answer to give them on whether or not these therapies are effective and safe. So we're going to talk about vitamin C, vitamin D, probiotics, turmeric, curcumin, echinacea, capsaicin, green tea, zinc, CBD, essential oils, colloidal silver, acupuncture, and then I'll finish with just some comments about tinnitus, because that is a diagnosis that has a lot of complementary and alternative therapies thrown at it. And I also want to mention too that when I did my literature review here for this talk, I tried to stick to clinical trials, because association studies, in my opinion, generally aren't very helpful for complementary and alternative therapies, because when you look at association studies, we know that the folks that use complementary and alternative therapies are generally healthier folks. So the association of a complementary therapy in a healthy person with a better clinical outcome isn't quite so helpful to me as a clinician. So we really are going to focus mainly on clinical trials here. So vitamin C has really been interrogated extensively with its relationship to the common cold. There's a 2013 Cochrane review, which was a meta-analysis of 29 randomized controlled trials, over 11,000 patients, and they found that daily supplementation with vitamin C was not helpful to decrease the incidence of the common cold in the general population. The supplementation daily with vitamin C was helpful in a special population of folks, and those are folks that are undergoing extreme physical exertion. So in that category of patient, those folks do benefit from daily vitamin C supplementation, and it's found that the incidence of the common cold is decreased in folks undergoing extreme physical exertion. And that was derived from some clinical trials on marathon runners, Canadian military personnel doing training, special ops training in extreme cold environments, and youth at a Swiss ski camp. That same meta-analysis did find that the duration and the severity of the common cold is decreased in the general population with daily vitamin C supplementation. So while it didn't decrease the incidence, the duration and the severity was helped by taking vitamin C. We find that 14% of children, we find that in children there's a 14% reduction in the duration of the common cold, and in adults there's an 8% reduction in the duration of the common cold. And then there was also a significant decrease in the symptom severity, and you can see the significant p-value there. There appears to be a dose-dependent response with vitamin C and the common cold, and that Cochrane study from 2013, that was a meta-analysis that I previously quoted. Again, they looked at clinical trials where patients got greater than 200 milligrams of vitamin C. So again, 14% reduced duration in the common cold for children, 8% reduced duration for adults in folks getting 200 milligrams or more. Now look what happens when you look at the clinical trials where patients got 2 grams or more vitamin C daily. That percent reduction in the duration of the common cold goes up to 26% in children and 21% in adults. So the higher the vitamin C there, the greater reduction in duration of the common cold. This is the European position paper on rhinosinusitis. This is a very comprehensive document that came out this year as a clinical practice guideline for otolaryngologists in treating rhinosinusitis. It's one of the most comprehensive evidence-based documents we have available to us in the treatment of rhinosinusitis. And it was a rigorously produced document. And the authors of this document come out and clearly state that there's level 1A evidence to support the use of vitamin C in prevention of acute viral rhinosinusitis. And they further posit that patients should test therapeutic vitamin C on an individual basis in the setting of the common cold or acute viral rhinosinusitis. All right, moving on to vitamin D. There's a lot of buzz about vitamin D these days. We do have a randomized controlled trial looking at its effects on acute otitis media. 116 children with recurrent acute otitis media, they were randomized to placebo versus 1,000 IU of vitamin D, and it was found that there were fewer cases of acute otitis media in the vitamin D group. This is a landmark paper from 2017 in BMJ. It's a meta-analysis that includes 25 randomized controlled trials, nearly 11,000 patients. It studied the effects of vitamin D intervention on the incidence of upper respiratory infections, and it clearly showed that vitamin D supplementation is associated with a statistically significant reduction in the rate of acute respiratory infections or common cold. Additionally, they found that vitamin D provided the strongest protective effect for those who had a baseline serum vitamin D level less than 10 nanograms per ml. And they found that daily or weekly dosing offered protection against the common cold, whereas monthly bolus dosing did not provide protection. Since that landmark paper or meta-analysis in 2017, we've had a few other randomized controlled trials come out. This is just one showing 2,200 infants that were followed from birth to 6 months. The treatment group was given 400 to 600 IUs of vitamin D daily, and the authors found that there was a decreased frequency of respiratory tract infection in the group that received that vitamin D daily 5 to 7 days per week. What about vitamin D and COVID-19? Again, a big buzz about that right now. What we can say is that there are multiple association studies, but at the time I wrote these slides, we don't have any randomized controlled trials on vitamin D supplementation in COVID-19, but there are multiple clinical trials ongoing. And you can go to clinicaltrials.gov to see those ongoing trials as the data comes in. And we do think, however, that there's an association between vitamin D deficiency and SARS-CoV-2 infection status. And we think that there's a potentially poor clinical outcome from COVID-19 associated with vitamin D deficiency. So it'll be interesting to see what those randomized controlled trials show. Moving on to probiotics. So to understand how probiotics work, we have to remind ourselves about the microbiome concept, and that is that humans have anatomically organized essential microbial communities that contain bacteria, viruses, and fungi. And we contain and we are covered with harmless commensal bacteria, helpful symbiotic bacteria, and some pathogens mixed in there as well. And it's actually the lack of diversity in that microbial community that results in pathology, or what we call dysbiosis. And the aim of probiotics is to restore that diversity through introduction of the appropriate symbiotes and commensals that we need. We're very familiar with gut probiotics as clinicians. They've been around for a while in capsule form, powder, kefir, yogurt, miso soup, kimchi, etc. But we're not so familiar with ENT probiotics. And if we're going to think about ENT probiotics, we have to remember that the flora of the oral cavity, the pharynx, and the sinonasal tract are different than the gut flora. Probiotics as therapy, that proof of concept has been done by our GI colleagues. We've long known that lactobacillus can prevent antibiotic-associated diarrhea. There was also a landmark 2013 New England Journal of Medicine study that compared fecal transplant, which is a form of probiotic therapy, to IV vancomycin for treatment of recurrent and recalcitrant C. diff infections. And it was actually found that fecal transplant was superior to IV vancomycin. And in fact, they had to stop the study after enrolling their first 30 patients because fecal transplant was so far superior to IV vancomycin that it became unethical to deprive the patients in the clinical trial of the fecal transplant. So we may be wondering, what about the nose? What about the throat? Will we someday be doing snot transplants? And it's likely that we may. So there is a body of literature that looks at topical probiotics in ENT. And you can see here on this table from this paper by Servin et al. In 2018. There are 7 trials here that look at recurrent tonsillitis, otitis media, and chronic rhinosinusitis, and 1 trial looking at clearance of MRSA carriers. You can see the indications, the treatment, the duration of therapy, and then the outcome. And I want to draw your attention to the top line there. If you look at recurrent tonsillitis, patients received an alpha streptococcus throat spray for 10 days, and that actually decreased the incidence of recurrent tonsillitis by 21%. Multiple studies looking at otitis media. These patients essentially got a probiotic nasal spray containing various bacteria, and 3 of the 4 studies showed benefit in reducing acute otitis media and serous otitis media. And interestingly, the second to last study there, the authors found that when the nasopharynx was successfully colonized by the nasal probiotic, the therapy actually worked. There was 1 study there on chronic rhinosinusitis, and those patients received a nasal spray probiotic, and there was no benefit in those patients. Probiotics and reflux, you may be surprised to know that Lactobacillus reuteri can accelerate gastric emptying and decrease regurgitation in infants, and Bifidobacterium lactis is associated with decreased regurgitation. Probiotics and allergic rhinitis, actually a growing body of literature for that. 2013, there was a randomized controlled trial of 20 patients. They found that Bifidobacterium lactis reduced allergic rhinitis symptoms and reduced IL-5 and IL-13 levels in their blood. Following that, a 2015 meta-analysis of 23 trials, 1,900 patients. 17 of those trials that were examined showed clear symptomatic benefit for allergic rhinitis sufferers, and only 3 did not show clear benefit. And then subsequent to that, a 2017 randomized controlled trial of 40 patients studying Bifidobacterium mix. They found reduced symptoms of allergic rhinitis and increased quality of life scores. So surprisingly, some growing body of literature there. What about probiotics and acute upper respiratory tract infections? Well, there was a Cochrane review that looked at 12 randomized controlled trials, 3,700 patients. in those folks looking at probiotics for prevention of upper respiratory tract infection, they actually found a 47% reduction in the incidence of the common cold, or URI. And there was a decreased duration of the URI by nearly 2 days in the probiotic group. With respect to chronic sinusitis, we don't have good data yet. There are 2 mouse studies that do show benefit, while the 2 human studies I reviewed did not show benefit. Moving on to acupuncture. This is a nice paper that came out in our literature this year. It looks at the efficacy of acupuncture in various different otolaryngologic diagnoses. They looked at 30 studies, including randomized controlled trials, meta-analyses, retrospective reviews, and high-quality pilot studies. They examined allergic rhinitis, tinnitus, sudden sensorineural hearing loss, post-viral olfactory dysfunction, dysphonia, and post-tonsillectomy pain and nausea. Breaking down the efficacy of acupuncture by diagnosis, when you look at allergic rhinitis, there were 13 studies, and the authors, based upon that meta-analysis, recommend acupuncture be considered as an effective and safe treatment for allergic rhinitis. When they looked at tinnitus, they found 2 randomized controlled trials and a meta-analysis of 18 RCTs and found no sufficient evidence that acupuncture helps with tinnitus. Chronic sinusitis, 1 pilot study without sufficient evidence to support its use. Sudden sensorineural hearing loss, 2 meta-analyses covering 21 randomized controlled trials, no sufficient evidence that it works. Post-viral olfactory dysfunction, 2 cohort studies without sufficient evidence that it works. Dysphonia, 1 randomized controlled trial, no sufficient evidence that it works. Post-tonsillectomy pain, we've got 4 RCTs with no sufficient evidence that it works. And post-tonsillectomy nausea, 2 RCTs, 1 showed benefit and was very strong, and the other did not. But collectively, the authors concluded that there's not sufficient evidence to recommend acupuncture for post-tonsillectomy nausea. Acupuncture and reflux. Randomized controlled trial of 60 patients, acupuncture alone versus omeprazole 20 milligrams daily. Both groups had better reflux symptom scores, 24-hour intraesophageal pH and bile reflux scores, and endoscopic grading scores. So these patients were interrogated extensively. And there was improvement in both groups. But interestingly, only the acupuncture group had sustained symptom improvement 4 weeks after cessation of therapy. What about acupuncture and chronic rhinosinusitis with polyps? We've got a randomized controlled trial, 66 patients that were randomized to medical therapy, which was an oral steroid and oxymetazoline, which is Afrin nasal spray, versus acupuncture, versus sham acupuncture. And they found that there was no statistical difference in the outcome in those 3 groups. However, the symptom scores were better in the medical treatment group. And the authors deemed that acupuncture was not helpful in CRS. This is another paper that came out this year in our literature, and it looks at various different complementary and alternative therapies, not including some of the vitamin therapies, but all the others. And they found that acupuncture had the most evidence to support use of any of the alternative therapies that they analyzed in their paper. And the authors conclude that there's moderate to high level of evidence for use of acupuncture in rhinitis, but not chronic sinusitis. Moving on to CBD. So CBD is cannabidiol. It's often administered as an oil. There are no studies on rhinitis or sinusitis, although it is marketed for sinusitis and allergy treatment. I did find 3 animal studies that showed some potential benefit on lower airway inflammation, but nothing in the ENT literature. There are some significant risks associated with CBD, including dry mouth, fatigue, diarrhea, and it can interact with a patient's anticoagulation therapy. A 2017 study that came out in JAMA actually looked at the quality of CBD available online, and they found that 50% of the products sold online actually had the dosage labeled inaccurately, and 20% of the online CBD products were actually contaminated by THC, which is the psychoactive component in cannabis. Colloidal silver. So there are some studies looking at colloidal silver in the nose, topical colloidal silver for chronic sinusitis. There were 22 patients in this prospective single-blinded pilot study. The authors studied colloidal silver rinse versus a culture-directed oral antibiotic and saline rinse, and they found that there's no difference compared to the oral antibiotic and the saline rinse. Another study on chronic sinusitis, again, 22 patients, randomized double-blinded trial, colloidal silver spray versus saline spray for 6 weeks, and then crossover, no difference in symptoms between the two groups. Colloidal silver can be associated with significant adverse events. I specifically want to discuss argyria. So even from topical intranasal use, you can get argyria, which is this deep blue pigmentation of the skin, and sclera, and if you've seen it, you'll never forget it. The most tragic or heart-wrenching case report I came across in the literature was a 12-year-old girl who was getting colloidal silver nasal spray, and she unfortunately developed severe argyria, and it had not resolved several years later. So this poor girl had to go through her adolescence and early adulthood with this deep blue pigmentation of her skin. Can also be associated with cardiomyopathy and seizures. And then anecdotally, in my practice, I've seen patients who've had permanent blue or black tattooing of their nasal mucosa from colloidal silver sprays. Essential oils. So essential oils, you may be surprised to hear that they are indicated for the diagnosis of olfactory loss. So we can recommend olfactory training for patients. The indications for something like this would be post-viral olfactory loss, so somebody who's permanently lost their sense of smell after a cold, post-traumatic anosmia or post-surgical smell loss. This leverages the neuroplasticity of the olfactory system. So the olfactory system seems to be somewhat unique in that the olfactory neuroepithelium in our nose can become more effective with time if it's stimulated properly. So we will have patients go through olfactory training and deliberately smell a combination of 4 different essential oils in a very disciplined fashion, and we generally recommend rose, lemon, eucalyptus, and clove. There's a standard protocol for this. There's actually a meta-analysis that supports the use of olfactory training, 10 studies, 640 patients nearly. It's a meta-analysis showing statistically significant improvement in threshold discrimination and identification of smells in patients who underwent training versus the control population. What about essential oils as aromatherapy for post-tonsillectomy pain? We've got a randomized controlled trial, 48 patients that were randomized to acetaminophen versus acetaminophen and lavender aromatherapy. They found that the aromatherapy group had less acetaminophen requirement, but there was no change in pain intensity or nighttime awakening with pain. What about essential oils for allergic rhinitis? Randomized controlled trial, 62 patients using essential oil aromatherapy versus placebo, and they found a significantly improved symptom score in the aromatherapy group. No difference, however, in sleep quality or fatigue. What about essential oils for acute upper respiratory tract infections? We've got a randomized controlled trial where patient used an essential oil throat spray versus a placebo throat spray. They actually found a significant reduction in symptoms at 20 minutes, but no difference after 3 days of use. They used eucalyptus, peppermint, oregano, and rosemary in the throat spray, and my presumption is that patients were experiencing a cooling effect of the eucalyptus and the peppermint that resulted in the immediate improvement in symptoms, but probably not doing much for the inflammation. Essential oils and sinusitis. There's actually a randomized controlled trial, double-blinded, 150 patients that took oral capsule form essential oil, which is cineol or eucalyptol, 200 milligram capsule versus a placebo capsule. And the authors actually found a statistically significant improvement in symptoms and nasal endoscopy with the oral eucalyptol. What about putting essential oils into a nasal spray or a nasal rinse? There were no studies available. However, this is already marketed to the public. There's a product called Xlear, X-L-E-A-R, and they have a spray that they call Rescue Nasal Spray that has saline, xylitol, and essential oils. So be aware patients may be using that already. Can essential oils be toxic? Well, in vitro, we think so. Eucalyptus oil can cause oxidative DNA damage to human cells. Tea tree oil and lavender oil were long thought to cause pediatric endocrinopathy, specifically gynecomastia in young males. However, recent meta-analysis suggests that there may be no link in that. And then anecdotally, we've been taught in our specialty that you should avoid placing essential oils near the airway of an infant because it could cause laryngospasm and bronchospasm. I couldn't find a study that was able to provide data for that, but multiple anecdotal reports in the literature. What about capsaicin? So capsaicin has been looked at with respect to rhinitis. 6 randomized controlled trials, 370 patients. They looked at non-allergic rhinitis and allergic rhinitis. Capsaicin spray versus placebo spray. All 5 studies on non-allergic rhinitis actually showed improvement in symptoms with capsaicin, whereas the one allergic rhinitis study did not show improvement with capsaicin. There are no randomized controlled trials on sinusitis, but a few small studies showed some benefits in patients with nasal polyps. Curcumin. So curcumin is the main component of turmeric. It's an antioxidant, and curcumin has been found in vitro to inhibit head and neck squamous cell carcinoma cell growth and proliferation, but we don't have any head and neck cancer clinical trials that look at curcumin yet. Curcumin has been looked at in the nose. There's a randomized controlled trial, 241 patients who had rhinitis. They took oral curcumin 500 milligrams daily for 2 months versus placebo, and the curcumin group had improved rhinitis symptoms. What about sinusitis? We've got no human sinusitis trials with curcumin. There are studies in rats, and curcumin was found to be improved therapy over antibiotics in case you have a pet rat. There are multiple meta-analyses on depression, cognition, ulcerative colitis, and hyperlipidemia, which all show benefit. However, as promising as it may seem, we don't have any meta-analyses in ENT disorders and curcumin yet. What about zinc? Zinc has been looked at for preventing otitis media. There was a Cochrane review, a meta-analysis of over 6,800 patients, which were children less than 5, and they found that zinc has no benefit in children who are healthy, but in children under 1 who are severely malnourished or have marasmus, zinc did show benefit in preventing acute otitis media. What about with upper respiratory tract infection? We've all heard anecdotally that zinc, or even we've heard that trials show that zinc is beneficial in preventing or treating acute upper respiratory tract infection. There are multiple meta-analyses looking at most of the same studies, even a Cochrane review. I do have to say that there was some controversy in the Cochrane reviews, and the most recent Cochrane review in 2015 was actually withdrawn because of plagiarism. However, there are enough meta-analyses that we have good reason to believe that zinc lozenges administered within 24 hours of symptom onset may result in significant reduction in the duration of the common cold. We believe, based on multiple studies, that zinc acetate lozenges are preferable to zinc gluconate lozenges because they release the zinc ions more readily, and it's thought that you need about 75 milligrams of zinc per day through the lozenges cumulative to get the most benefit. Now, that being said, just this year, a randomized controlled trial came out. This was published by one of the authors of a previous meta-analysis. They published their own trial, randomized controlled trial, 87 patients who contracted a viral URI. Patients were randomized to zinc lozenges versus placebo lozenges. They were getting 78 milligrams per day total of zinc, and it actually came out that the zinc group had no benefit. And in fact, the placebo group had a shorter duration of symptoms. So now I'm not so sure if zinc is helpful for the common cold. What about zinc and tinnitus? We've got a Cochrane review of 3 trials, 209 patients. There's no evidence that oral zinc improves tinnitus. Moving on to Echinacea. So Echinacea and viral rhinosinusitis are common cold. Cochrane review, 4,600 patients, Echinacea versus placebo for prevention and treatment of the common cold. None of the studies individually showed reduced incidence or duration of the viral URI with Echinacea. However, when they pooled the meta-analysis data, they did find a 10% reduced risk of viral URI. The real interesting part with Echinacea is in patients who are at risk for recurrent acute upper respiratory infections in cold and flu season. There was a meta-analysis, 6 RCTs, 2,400 participants, and they found that in those patients who normally get recurrent acute infections, there was a 35% reduced risk of recurrent infection with Echinacea, 50% reduced risk of infection in at-risk populations, such as those with immunodeficiency or those under heavy stress, and a 50% reduced risk of complications of the acute URI, including decreased otitis media, tonsillitis, and pneumonia. Green tea, I am guilty here for putting in an association study. I could not find any randomized clinical trials on green tea in the ENT literature, but I thought it was interesting that there's a 6% reduction in the risk of head and neck cancer for each cup of green tea you drink per day. And then I want to finish here with a brief note on tinnitus, because there are so many alternative and complementary therapies thrown at this diagnosis and marketed for this diagnosis that our academy, the American Academy of Otolaryngology-Head and Neck Surgery, actually came out with a clinical practice guideline that states clearly, based on meta-analyses, that clinicians should not be recommending dietary supplements such as ginkgo biloba, melatonin, zinc, or others because they're not effective for tinnitus. And clinicians should not recommend acupuncture because it's also not effective. So here's the summary table. Very quickly, we'll run through it. Vitamin C, I gave that one a green light because it seems to be beneficial in decreasing the duration and severity of the common cold in the general population. Also, it decreases the incidence of the common cold in special populations under a lot of stress. So think about our young athletes. Vitamin D, gave it a green light, decreased risk of upper respiratory tract infection and decreased risk of acute otitis media. Probiotics, gave that one a green light as well. Surprisingly, there's evidence to show that it's effective for allergic rhinitis and reflux. Acupuncture was probably the most surprising to me. I gave that one a green light because there's sufficient evidence that says it's helpful in allergic rhinitis and reflux. CBD, I gave that one a red light. Risks outweigh benefits, and we just have concerns about the dosage and the contamination. Colloidal silver, gave that one a red light. Risks outweigh benefits. Essential oil, green light when you're talking about olfactory loss and olfactory training. We've got good evidence that it works for olfactory training and getting a patient their sense of smell back. Capsaicin, I gave that one a yellow light. There is some literature that supports it. It's not robust for non-allergic rhinitis. Curcumin, I gave that one a yellow light. Rhinitis seems to be beneficial. Zinc, gave that one a yellow light as well. Seems to be helpful in malnourished infants and preventing acute otitis media. And we've got a previous body of literature that says that it's helpful in decreasing the symptoms of a common cold, but with that recent randomized controlled trial, it doesn't get the green light. Echinacea, surprisingly, green light for recurrent upper respiratory tract infections in those at-risk populations. And green tea, I had to give that one a green light. Again, guilty, that's an association, but I think it's generally safe. Thank you very much.